Good evening. I'm Dr. Michael Greiner from Medical Arts Clinic here in Fairfield, Iowa, and I'm here to talk to you tonight about women's health. And for the first time in 5 years, I've given the talk a title. And tonight we're going to be set for life. Before we get started, I'd like to thank a few organizations and groups tonight. First, I'd like to thank the Hospital Auxiliary, who has sponsored this, I believe, at least for 5 years, if not longer. I'd like to thank the Jefferson County Hospital for also sponsoring, Fairfield Public Access and Richard Thompson for videotaping tonight, and I'd like to thank the audience for coming and listening to me. Over the last 5 years I've done this talk, and each year it's been slightly different. Part of it's because there's always change in medicine. We learn new things, there are new studies that are available, and we just become a little bit more in touch with our patients and try to adapt what we know to making your lives better. Much of the changes that we make are dictated by research, and every time you talk about research, everybody kind of gets a little scared because all of a sudden I mention the word statistics. When new studies are released, the first thing you see on the newspaper is, this causes 36% more of this, or aspirin decreases the risk of heart attack by 50%. And the media gets all of us upset. We call our doctor and say, are you sure that medicine I'm taking is okay? Or you call someone else and you ask them, or you talk about it when you're having coffee with a group of people. Percent is a very easy way to make people feel uncomfortable in talking about medicine. And the reason is that it can make something look really overblown. And I'd like to show you just really quickly. If I told you that Dr. Greiner invented a new medicine, and it was going to decrease the risk of breast cancer in 50-year-old people by 50%. Sounds like a great deal, right? Okay. What really makes the difference is how many of those people are going to have a heart attack in the first place. If you take a group of people that have very low risk for heart attack, women who aren't going through menopause yet, maybe the risk of a heart attack is 4 out of 100. If you decrease that by 50%, half of 4 is 2. So we'll decrease the risk of a heart attack from 4 per 100 to 2 per 100. Now aspirin's inexpensive, it's easy to take, it has relatively low risk. It's a good deal, right? What if I told you that in order to decrease by 2, the medicine costs you $100 a month, thereby $1,200 a year, and $6,000 over 5 years? Doesn't sound like such a good deal, does it? On the other hand, if 50 women or 50 men out of 100 have a problem, and the new medicine decreases it by 50%, all of a sudden what happens? It's a much larger number. 25 people are going to benefit instead of the 2. So whenever we talk about medicine and research, new studies and new medicines, you have to know how many people in a group are going to have a problem. If you don't know that, it doesn't tell you a whole lot. So 36% and 50% can sound like really big numbers, but it may not be. So just as you read the newspaper and as they print new things, just keep that in mind if you could. The other issue that comes up is individual versus group. It's going to be very difficult. Most studies deal with large numbers of people. One of the studies I'm going to talk about tonight is the Women's Health Initiative. It deals with 18,000 women. And they whittled it down to about 16,000 and broke it into 2 groups of 8,000. And during that study, some numbers made a difference of 5 incidences of breast cancer or 10 episodes of a heart attack. If you look at 10 out of 10,000, for the individual, it may not impact you very much. For the one person that gets the disease or the problem, it's a larger deal. So you have to think about, as we're talking about medicine, whether the study was designed to look at a whole group of people across the United States. Insurance companies love it when we look at large numbers because then they can save money perhaps. If something is proven not to be effective and they can save money on a prescription or on a test, it makes sense to them to say, well, it doesn't benefit the group. But at the same time, you have to consider what is best for you as an individual. So one of the common themes that's going to come through tonight is knowing what your risk is. And only you and your doctor are really going to be able to figure that out. And you're going to get sick of hearing it over the next few years. It used to be you walked in the doctor looked at you, and the doctor told you what to do. And now all of a sudden, the doctor actually has to talk to you guys. We have to sit down and we have to find out what happened to your family, who your family is, what they died of, what you do, what you don't do. Do you smoke? Do you drink? Do you eat too much? Are you too heavy? All of those things determine your risk for bad things happening down the road. So you have to sit and talk to your doctor. You're going to hear that over and over and over again. The next issue is going to be, and you may not like me for this, but every single time I looked at osteoporosis, coronary artery disease, stroke, two other things kept popping up. Diet. Not dieting, but watching what you eat in terms of what your diet is. And the second is exercise. So as we go through these things, diet and exercise will probably be the dirty, nasty words. But I think long term, if we look at diet, exercise, knowing what your risks are, and emphasizing prevention, prevention's a lot less expensive than treating diseases. And in addition, rather than preventing a disease once it's happened, maybe you'll have a better life if we stop it from starting all over, okay? We're going to focus on breast cancer, osteoporosis, and coronary artery disease tonight. That's like heart attacks and high blood pressure. But there's a quick review I want to do of a few other things. Blood pressure is important. It's tied into coronary artery disease, heart attacks, and strokes. But you should think about getting that checked every 2 years at least. You know, the hospital does blood pressure checks. Oftentimes pharmacies offer them, and doctors' offices too. At least twice a year. I mean, every 2 years. We're not going to focus on pap smears a whole lot. Generally, this talk has been focused on women that are perimenopausal or a little bit later. But the bottom line is, at least at age 18, generally we recommend it. Yearly until you have 3 normal pap smears, and then every 3 years after that. But that's just the pap smear part. It doesn't involve the internal exam the doctor may do to check your ovaries or check for colorectal cancer, and also the breast exam. The pap's only one small part of that, so you still need to keep your yearly exam. Colorectal screening has become very, very important in the United States. We're decreasing the incidence or the number of invasive colon cancers and the number of colon cancer deaths. Colon cancer screening is relatively easy, somewhat embarrassing, but for those people that are older than 50 and don't have a family history, doing something as simple as taking a sample of bowel movement, putting it on a card, and sending it to your doctor's office can look for blood in your bowels and make sure that you don't have a problem. If you have a first-degree relative, mother, father, sister, brother, that has had colon cancer, it is recommended that you at least get a colonoscopy at age 50. If they had the colon cancer at a younger age than 50, then it's encouraged that you start at the age that they got the colon cancer. Like I said, somewhat embarrassing, but it's still very important. Thyroid is also a relatively common disease, especially amongst women, especially low thyroid. If you have a family history, you should talk with your doctor about making sure that your thyroid's okay. Simple blood tests will determine that. Eye exams, one of kind of the forgotten things, every 3 to 5 years just to make sure things are okay on that also. And the final thing I want to talk about is diabetes. Probably the largest epidemic in the United States right now is diabetes. And it's not type 1 diabetes, the child who gets diabetes before kindergarten or first grade or at young ages, but we're talking about adults getting diabetes. Most commonly, family history and obesity are the 2 things that cause diabetes in adults. We are seeing more and more young children have diabetes of adulthood and not juvenile diabetes, and all of it is related to obesity. If you have a family history of diabetes, or you are heavy, or if you have high cholesterol or high blood pressure, it's recommended that you do get a blood sugar test done once a year. They say that the average time from when you develop what is called pre-diabetes until you have full-blown diabetes can be as long as 7 years. And during that 7 years, a lot of damage can happen to your body. So it is encouraged, if you fall into those groups, checking a blood sugar, which can be as simple as just a finger prick, every year makes a lot of sense. Okay, now to what you really came for. So in talking about being set for life, since it's Halloween, I decided we kind of scare you with statistics, okay? So that's what the S is for tonight. The E, we're going to encourage you to A, change if you need to, and B, to be aware of what your risk factors for the 3 diseases that we're going to talk about. And then the T is going to be we're going to talk about treatment. So we're going to break each one of these into those 3 sections, and we're going to start first with osteoporosis. Osteoporosis, compared to heart attacks, strokes, and breast cancer, doesn't seem quite as glamorous, probably not talked about quite as much, but probably in women age 60 and older is a larger epidemic, a larger health concern than the other 2. 1.5 million women a year have fractures because of having thin bones. That's 1 every 20 seconds. Half of the women in their lifetime will have a break, and those breaks are either going to be in your wrist from a fall. When you fall on an outstretched arm, then one of the bones in your arm can break, or your backbone, or a hip. The sad thing is that if you're over age 75 and fall and break a hip, in 6 months, 35% of those women have died. The complications of hip surgery can be very devastating. Another 15 to 20% don't get a chance to go home and end up in a nursing home for the rest of their life. So being able to prevent thin bone will save a lot of women their life and maybe quality of life. One of the things I oftentimes hear at the office is, well, I don't feel bad, so it's okay. Well, unfortunately, you don't feel osteoporosis. You don't feel thin bone. You only notice it after you fall and it hurts. And so what you have to do is you have to be aware of those things that are risk factors. What are risk factors for having osteoporosis? Women have osteoporosis more than men. Men can get osteoporosis, but their bone structure is much larger, so they're much lower risk than women are. Women who are fine-boned are at a higher risk, so petite women are at much higher risk than women who have a slightly larger bone structure. So if you complain about clothing not fitting and large bone structure, it's one of the good things about it. Increasing age. As you age, your bone density will drop. And in fact, if you do not take any medications after menopause to help encourage you to keep your bone, you will lose 20% of your bone density in the first 5 years of menopause. And even if you start a medication at the end of that 5 years, you will not gain the bone density back. You may increase the strength of your bone slightly, but you'll never gain that back. Being Caucasian and Asian also is a risk factor. Decreased estrogen, which goes along with menopause, will also cause that. The reason I mention decreased estrogen is for those women who have had hysterectomies with their ovaries removed at a younger age than menopause are especially high risk. So if you had a hysterectomy at age 30 and you did not take hormone replacement, that places you especially at high risk. Those women who smoke, it definitely decreases bone density, partially because the smoke decreases bone formation, and secondarily is that generally those women who smoke tend to be slightly thinner than those that don't. And being thin, again, one of the bad things is if you're light, you don't have quite as much stress on your bones. It's one of the few things that having a medium frame is good for. Decreased activity. If you have a job where you sit down, if you're not active, will also decrease your bone density. Alcoholism will also, and also calcium. One of the predicted largest groups that are going to have problem with osteoporosis are those women currently that are between ages 14 to 15 and 30 to 35. Dietary calcium intake probably is lowest in them of all groups. So if you want to get on your kids and grandkids, calcium intake is very important. You will form the bulk of your bone by the time you're 35. If you don't form bone by 35, your odds of catching up are very, very slim. You can hope to hold it, but you're probably not going to get to your maximum potential. So if you can go out and be messengers for me, you don't have to yell, but just slightly encourage them to make sure that they're getting 12 to 1,500 milligrams of calcium a day with some vitamin D. Because the bone they build up now is just like gathering money for retirement. It will make a difference for them. So we've scared you with the numbers, and we're kind of encouraging you to change the diet. And then the next option is, how do you talk about treatment? If you do have thin bones, what do you do? There's a group of medications that you can use. The first group of medicines that's been used is hormone replacement therapy, and that's what you think about as estrogen, and we've done that for a long time. Another group is something called synthetic estrogen receptor modulators, which basically is fake estrogen. It doesn't cause the things that estrogen does, but it does protect your bone. And then there are a group of medications called biphosphonates, which also will help to hold your bone density so that it doesn't drop. And finally, there's a nose spray that you can use that can also help, and that's called miacalcin. And there are a few other things that are being researched at the present time. I'm going to talk about those a little bit more in depth when I talk about kind of a lifelong strategy. Any questions about osteoporosis?
Does strength training help that? I mean, you say you never get it back, but does that help?
The question was if strength training will help. And the issue is anything that causes muscle to pull on bone will help to increase bone density. So walking, lifting, biking won't help as much as walking will. Swimming won't help probably as much as walking on a treadmill. Something that causes an impact will help to maintain your bone density more. There's this neat little thing called piezoelectric potential. And it's a little miniature electrical shock wave that every time you walk goes through your body, and especially your bones. If you have a gas grill and you push the little button to get it started, there's a little spark that happens when you push that button that lights the gas. Well, the spark in your bone isn't quite as much as that spark. But that spark will then actually cause bone to be formed. So every time you walk, you're causing a piezoelectric potential. And that will help to keep your bone nice and strong. Any other questions? Heart disease. Interestingly, everybody's worried about dying from breast cancer and worrying about osteoporosis, but 69% of women are going to die from heart disease and strokes. So we can probably make the biggest difference in women's quality of life by paying attention to coronary artery disease, which is hardening of the arteries, if you want to use that term also. It's 2 times more common than breast cancer as a cause of death, 4 times more common than fracture as a cause of death. What places you at risk for heart disease? Males greater than 50, but we don't have to worry about this in this room except for me. I'm not there yet, a few years. Diabetes, high blood pressure, if you have a family history of heart disease, and if you have high cholesterol. So we scared you with statistics. So what are we going to do? Exercise. 30 minutes, 3 times a week drastically decreases the risk of heart disease. It doesn't have to be fancy walking. You can just go out and a nice leisurely walk, 30 minutes, 3 times a week will definitely help out with that. You'll also help with your osteoporosis too. Diet. We're a very affluent country. We have more protein in our diet probably than a lot of countries, and most of the time with protein comes fat. And the fat leads us into problems with our cholesterols. We supersize everything. Everybody wants us to supersize it for what, 69 cents? You pay for that 69 cents for a long, long time. Most of the time, the rest of your life. You don't have to supersize it. Just that one thing will save you an amazing number of calories and an amazing amount of fat. Smoking. We've made inroads on smoking. We still haven't reached what we'd like to. But smoking definitely increases the risk of heart disease. So those are the things that we'd encourage you to think about. Those changes that you can make that are relatively simple. Now, the next issue is there's some things that you're born with. You can't pick your parents, or at least not yet. And there are some things that you inherit that we can make a big difference on, but unless you talk with them with your family, they're not going to know, and they're not going to know to look. And a couple of the neatest things in the last few years, especially in heart disease, is in those families where it seems like everybody dies at age 60 of a heart attack, and we didn't know why, or we said, well, gee whiz, their cholesterol was normal, why'd they have a heart attack? And they didn't smoke, and they weren't fat, and they didn't sit all day long. There's a few special tests that really should be considered. Everyone should know what their cholesterol level is. Good cholesterol, bad cholesterol, and your triglycerides. Easily done. Go to your doctor's office. You can go to a screening here at the hospital. Pharmacies offer screening at least every 5 years. Get the basic cholesterol done. If you have a family that has been blessed with the unfortunate gene, there's a few things to think about. One of them is called homocysteine. And homocysteine is a chemical that can build up in your bloodstream. And if it builds up, it increases the chance of cholesterol being deposited in your arteries. And cholesterol going in your arteries can kind of be thought about like rust forming on the inside of a pipe. And as that rust forms on the inside of a pipe, eventually the pipe collapses, the rust collapses. And homocysteine increases the chance of that cholesterol sitting on the surface of those arteries and causing them to plug. Not many families have problems with homocysteine, but the great thing about it is if you find it, it's easily treatable. All you need to do is take folic acid in higher doses than you would take in a multivitamin and follow the level of homocysteine until it's in a normal range. Very simple to do. I just talked to a gentleman today who has a strong family history, has a high homocysteine level, and now it's back to normal. At the present time, I'm probably finding 5 people a month with high homocysteine levels. Folic acid is relatively inexpensive. The test is a little more expensive than a standard lab test, but if you have a strong family history of heart disease, it makes sense to check that test. The next one is something called lipoprotein little b, or little a. I'll just write little a, it'll be easier. Lipoprotein little a is a carrier for cholesterol. And what happens is that it increases the chance for the cholesterol to stick to the arteries also. Lipoprotein little a is separate from your cholesterol numbers. You could have perfectly normal cholesterol numbers, but if your lipoprotein little a is high, it places you at just as high a risk for having a heart attack as if you had a high cholesterol. Again, easily done. It's a simple blood test. You can have it done fasting at your doctor's office. If you have a high lipoprotein little a, currently we don't have a way to decrease the lipoprotein, but we can lower your cholesterol into a different grouping, and by doing that we can decrease your risk. Normally we talk about bad cholesterol, that's the LDL. We like it to be less than 130. And if you have a high risk, most of the time 2 risk factors, or a lipoprotein little a that's elevated, we'd recommend that your LDL be less than 100. Most of the time, in order to do that, you end up having to take medications. And that could be Lipitor, Mevacor, Zocor. You've seen all the ads probably. And that's something you can talk with your doctor about. But in those families that are at very high risk, the lipoprotein little a and the homocysteine are 2 tests that I'd strongly encourage. The third test is called sensitive C-reactive protein. Sensitive C-reactive protein measures inflammation in your body. And the process of clogging arteries is actually a process of inflammation. And over the last few years, we found out that that inflammation can be measured by measuring this sensitive C-reactive protein. Again, easily done. All you need to do is a blood test at the doctor's office. All 3 can be done in the same tube of blood, in fact. If we find that you have a high sensitive C-reactive protein, again, there's nothing specifically that changes it, but we encourage you to take an aspirin every day and also talk with you about lowering your cholesterol and the dirty E word, exercise again. And by doing those things in those families at high risk, we can make a big difference in the number of heart attacks. So if you have a family like that or you know families like that, let them know about it. It's relatively new. Probably over the last 2 years we've been much more aggressive about this than we had in the past. Americans in general are doing much better on their cholesterol. Cholesterol awareness has truly increased. Always diet and exercise are the first 2 things. We do have medications that can help to lower your cholesterol. But at the same time, sometimes you fight genetics. And if you're fighting genetics, your doctor can help you with that. The next is breast cancer. About 43,000 deaths a year from breast cancer. In the 15 years that I've been a physician, it's been interesting because breast cancer formerly almost seemed like a death sentence, and now breast cancer is almost becoming a chronic illness. Many women are living years and years with breast cancer. But again, as we talked about, if we can prevent invasive breast cancer, it's going to be the most important thing. The lifetime risk of getting a breast cancer for an average woman is about 45 per 1,000. Again, numbers don't really make a difference. If you're one of those 45, it's devastating. If you are one of those that didn't get the breast cancer, then it's a great thing, but you can't let things up to chance. You have to be aggressive about knowing what your risks are again. Recently, as I talked about the Women's Health Initiative, or what I was calling the WHI, there were lots of questions about breast cancer and also about heart disease and osteoporosis. But the breast cancer risk increased on those women that were taking estrogen. But one of the things that most of the media didn't talk about was it was a specific kind of estrogen with another medication. And so as we talk about the lifelong strategy, I'm going to talk with you about that too. But overall, estrogen will slightly increase the risk of breast cancer if you take it with something called medroxyprogesterone. And what we're talking about now is if you're taking estrogen, thinking about taking it for hot flashes, if you need to. And it's interesting for me as a man to read all of this literature. So it says estrogen is for severe hot flashes. Now, how am I as a man to tell you whether your hot flash is severe or not? I wouldn't even venture to guess to tell someone that. So you have to talk with your doctor. You have to make some decisions, the decision thing again. But we'll talk about estrogen and how things are changing with estrogen therapy. And I'm sure a few of you have been on estrogen in the past, and I'll give you the current thinking, and we'll talk about that. Self-breast exam is still the most important thing in breast cancer. I can't tell you how many times someone comes in with a lump and you say, "Did you check your breasts?" No. When was the last time? 2 years ago. The best example that I can ever give about doing self-breast exams is that if you drive from your home to the hospital back and forth twice a day, you get to know where every stop sign is and you get to know where every pothole's at. And you wonder why the city didn't fill the pothole, right? If you do a breast exam every month after your period, if you're still having periods, or the first of the month if you're not having periods anymore, you're going to know what your breast is like. I think when you first start medical school, and you're talking about breast exams, everybody thinks that breasts don't have lumps and bumps and irregularities. Every breast I've ever examined at the office has a little lump or bump here or there. The issue is there a change? And you're only going to know if there's a change if you examine yourself. It only takes 3 to 5 minutes. It's quick. It's easy. Self-breast exam still is going to be the best ally we have against fighting breast cancer. So if you can do that every month, it makes the biggest difference. Mammograms are continuing to make a huge difference in breast cancer. In the last year, I would estimate that I have found 5 to 7 breast cancers on mammogram that the woman couldn't find on self-breast exam and I could not find by doing a breast exam on her. They state that the average breast cancer is there for 5 years before it becomes palpable, meaning that you can feel it. A mammogram can pick up that breast cancer much earlier. Now, there are some breast cancers that rapidly grow that you can't find on breast exam and you can't find on mammogram, and it's a very unfortunate thing. On the other hand, many of the breast cancers you can find very, very early on mammogram. And so mammography has really made a difference. And the biggest difference it's made is it hasn't decreased the number of breast cancers because those cancers are still there and we're still finding them. But what's making the difference is we're curing women. We're having women that are 35 coming in. We're finding a breast cancer. We're able to do a lumpectomy with radiation, treat them with medications for 5 years, and the bulk of those women are cured, not to face cancer again. They always think about the cancer, but they're cured, and that's what makes the biggest difference. There are studies out there that talk about breast cancer and what's the best way to screen for it. The Canadians did a study a year ago, and I talked about it at my talk last year, where they said that a careful breast exam by a physician was just as good as mammography in changing the death rate from breast cancer. Well, I have a problem with that. When you talk about studies, like we were talking about earlier, you have to decide what outcome you're going to measure. If you measure an outcome of did a woman die or not from breast cancer, that's not acceptable to me. What makes the difference is did she have to live with breast cancer for 5 years or 10 years? And so I'm not convinced that the Canadian study really gave us any good answers. Sure, it may save money because you're not doing a mammogram every year, but on the other hand, having a woman having to live with breast cancer for 5 or 10 or 15 years doesn't seem to be acceptable. Currently, the American College of Radiologists, that's the guy that always looks at your mammogram, and the American Cancer Society says that every year after age 40, every woman ought to have a mammogram. There are other groups that have other guidelines. If you have a strong family history of breast cancer, then you should consider yearly at 40. If you don't have a strong family history, you could consider every 2 to 3 years without sacrificing any risk. One of the things that you can talk about with your healthcare provider at the office is something called the Gale model. The Gale model gives you an idea of what your risk of breast cancer is over the next 5 years. You can have a little fancy calculator like I have, or the other way you can do it is it's actually printed out on sheets. And if you open it up, if I can, it just asks you 7 simple questions. First one is what your race is. Caucasians that are a higher risk of breast cancer. The next is your age. Increasing age increases the risk. How old you are when you had your first period. The reason for that question is how long your body is exposed to estrogen over your lifetime increases the risk of breast cancer. So those women who had onset of their first period at 12 may be at slightly higher risk than those women that didn't have their first period until they were 15. The next question is how old you were when you had your first child. Having a child at a young age is protective for breast cancer. Not necessarily desirable in your teenage years, but from a breast cancer standpoint, probably makes a big difference. Catholic nuns have the highest risk of breast cancer. Most of them haven't had children, and most of them have not breastfed, and that probably makes the biggest difference. The number of mothers, sisters that have had breast cancer also impacts it, and also if you've had breast biopsies in the past. You can do this in about 30 seconds, and it can give you a very good idea of your risk of breast cancer. If you're a woman that is approaching menopause, I hate to give ages because I always get in trouble, but if you're a woman that's getting close to menopause, and if by doing the Gale model, your risk of breast cancer is higher than 1.67% over 5 years, there are some studies that have shown taking a medication for 5 years can decrease your risk of breast cancer. That study was completed about 4 years ago. It involved the University of Iowa and also a cancer group in Cedar Rapids. And so if your doctor does the Gale model and you come up with that, your doctor may talk with you about whether or not you would be a good candidate. And the name of that drug is tamoxifen, if you've heard of it. We also use it if you have breast cancer, but it can actually decrease the chance of you getting breast cancer. The idea of the tamoxifen is it blocks the estrogen. And if you block the estrogen for a 5-year period, it is felt that you starve any cancer cells or cancer-prone cells from growing and becoming more dangerous to you. Any questions? So 3 years ago when I stood here, we talked about estrogen being the be-all and end-all, and that when you got into menopause, that estrogen probably was going to be a good thing, and that if you didn't have a reason not to take estrogen, that you should go ahead and get started on it. And so there's a lot of women that took Premarin and a whole list of medications. If you still had a uterus, you took that thing called medroxyprogesterone also. They did this large study, this Women's Health Initiative study, and it made the newspaper about 4 or 5 months ago that they had stopped the study early because it presented women too much risk. And so we had a lot of calls at the office, a lot of women stopped their estrogen, and it kind of created an uproar because everybody had questions about it, and doctors had questions about it too. If you look at what happened, remember that percent thing we talked about? This will be a way for you to see that some of the numbers the media presented really weren't as threatening as to the individual as you thought. If you took 10,000 women that were in this study, and if they took estrogen plus medroxyprogesterone, the risk of breast cancer increased from 30 to 38 out of 10,000. Does that seem like a lot? An increase of 8 per 10,000. I mean, when you look at it that way, it doesn't look that bad. But if you put it as a percent, increasing from 30 to 38 increases that percent to 26% increase. If I tell you there's a 26% increase, you panic, don't you? But the reality was 8 women out of 10,000 were affected by breast cancer more. They also didn't look at whether your hot flashes were controlled, whether it helped your vaginal dryness, whether it increased your sexual desire, and some of the other things that estrogen have been used for. If you go down the line at other things, in heart attacks, the number of heart attacks increased by 7, so that was going to be about a 29% increase, and stroke slightly increased too, and blood clots increased slightly. The estrogen decreased the risk of colon cancer by 6 out of 10,000 and decreased hip fractures by 10. They stopped this study after 5 years because they felt that the benefits, decreasing colon cancer and bone breaks, were outweighed by the negative things that happened, in that the increasing breast cancers and the increasing heart attacks. And so that was why they stopped the study. There was another part of the study where women only took estrogen without that medroxyprogesterone stuff. So if you didn't have a uterus anymore, you probably didn't take the combination drug. So you were only taking the estrogen. That part of the study is still going on because the differences weren't showing up yet. What's going to happen? Everybody has their idea. Some think that the estrogen is going to be bad no matter what. Some people think that it was that medroxyprogesterone stuff that caused the problem. It's probably going to be 5 years before we know for sure. And so what we're left with is a question on how do we handle things now, because there's lots of women that want to know, and 5 years is a long time not to know. So what it's prompted me to do is to think about women's health, menstrual years, osteoporosis, risk of heart disease in segments as you go through your life. And basically, we're going to have 4 segments to this. And so each one's kind of going to be a little hump. Now notice, I'm not putting ages on because we're not going to talk about how young you are, okay? So, the first section here is going to be, we're just going to put a P here. And it's going to be the years that you're menstrual, the years that you have periods. And what are we going to do for your health, okay? We went through all the you, and now they encourage the change and the treatment. So we're kind of talk about some of the changes and also the treatment. So what are you going to do during this time? I think about this kind of like building a house. If you think about your whole life like building a house, right? So you build the house, and you live in it, and then you have to maintain it. Well, your body's kind of the same thing. And during your menstrual years, we didn't really do much in the past. But we've hinted at a couple of the things. One of the large ones, we're dying. Calcium. If you can make sure during those years you're getting your 12 to 1,500 milligrams of calcium, you're going to be building a great foundation for your retirement years, for your postmenopausal years. So the more calcium you can get, the better. One of the questions last year was, if I've had kidney stones, should I be taking calcium supplementation? And there was a recent study that said as long as you maintained your water intake and didn't exceed the 12 to 1,500 milligrams, they felt that the benefit of strong bone outweighed the risk of getting a kidney stone. So encouraging everyone. 1,500 milligrams of calcium you can get in 3 500 milligram calcium tablets. It'd be great if you could get some vitamin D with it. The other option is 4 servings of dairy product. Milk, ice cream, yogurt, cheese. A lot of women just don't get that much dairy in a day. One of the concerns I think about dairy is the amount of fat. If you can go to a skim product, skim milk cheese, skim milk yogurt, that'll save you some of the fat calories, so we stay away from the heart disease thing. The other issue is the E word again, exercise. Exercise is going to help stop the heart disease. It's going to help build those bones. Again, it's going to really build a great foundation for your house for the rest of your life. So if you can do those things, it's going to be the most important. Now you still have to do a few preventative maintenance things every year. You need to get your yearly exams and the blood pressure checks and all of those things. But truly from a preventative standpoint, those things are going to make the biggest difference. I know you can't read that, but I'll tell you, it's perimenopausal. What does perimenopausal mean? Perimenopausal is the time from when your periods start to get irregular, you maybe get a hot flash in the middle of the night, not routine, you're still having some periods. I'm not going to venture on a timetable here, but they say perimenopausal years can start as early as age 35, even if you may not go through menopause until age 45 or 50.